That was a talk on a satellite symposium during ESMO Breast this year, together with Fatima Cardoso and Professor Jurich from the US, and Fatima Cardoso from Portugal, obviously. And we were discussing a case of a hormone receptor positive, HER2 negative breast cancer patient. And we were discussing the different options. And actually, to put it in a nutshell, in the discussion, we discussed the guidelines a lot because Professor Cardoso is head of the ABC Commission. And so the decision in that case for a HER2 positive, HER2 negative hormone receptor positive breast cancer patient with liver metastasis was the decision to give her a combination of an endocrine therapy and ribociclib, a CDK4/6 inhibitor. And as we mentioned in that panel discussion, when I was in medical school 25 years ago, we learned that the median overall survival of a breast cancer patient with metastatic disease was 2 years. And now we're talking about 2 years of progression-free survival in first-line therapy, not to mention overall survival. So something really has changed in the course of the disease due to the new medications we have. And the CDK4/6 inhibitors really have been a revolution in that. And after the patient was 26 months on stable disease on ribociclib, she definitely had a progression. And we were discussing, of course, the options for the second-line therapy. And in that, we stressed that it is very important to have an information about the PIK3CA mutation status. PIK3CA is, on one hand, a prognostic marker indicating a poorer prognosis in these metastatic patients, and on the other hand, a predictive marker for response to a PI3K inhibitor, an alpha-specific PI3K inhibitor, alpelisib. The results we were discussing in first line were based on the Mona Lisa trial, and the results we discussed in the second line were based on the SOLAR trial. And so in patients who have a PIK3CA mutation and have an indication for second-line metastatic therapy. At the moment, we were we all agreed that a combination of fulvestrant and alpelisib is actually the best option for those patients. We were discussing toxicity a lot. The patient in that case was diabetic. It is crucial to really monitor the blood sugar in these patients. You have to do fasting glucose. You have to do plasma glucose tests and hemoglobin AC, 1AC testing. So it's crucial in these medications not to think that it's simply an endocrine therapy, but we have to monitor different toxicities. And if that is really done, we can definitely offer patients therapies prolonging their PFS significantly. Another thing that really has to be discussed with PI3K inhibitors is the rash, dermatologic toxicity. This also has to be monitored. Sometimes, in some people, we do even recommend giving prophylactic antihistamines, and then these toxicities can really be managed. And we have a second-line option that allows patients to go on with their normal life, although they're in second line of metastatic therapy. And we see a development in Germany. We have a study group, the Pregnant Study Group, and we have a large network. We are measuring in first line how many of those patients are receiving first line chemotherapy, and that has reduced over the last years from almost 48% down to about 25% now, due to the fact that we have those new medications that allow us to keep patients off of chemotherapy for a very, very long time and keep them in endocrine combination therapies, which is definitely a benefit for the patients.